Oh, hello, hello. Happy Thursday, everyone. Um, I feel like it is somewhat of a new beginning on this Thursday, for so many reasons. It's the first ever many things. On a global note or more big picture note, it's the first ever VMR on Thursday after match day last week. And it feels like we had so much to reflect on for so many people's journeys. And again, I will emphasize that um, for all of you dedicated enough to be here, I think match day is either a joyous celebration or a temporary blip, and one that will either be bringing you a tremendous amount of joy or be helping you develop your resilience and reinforcing your passion for medicine. So whether that's somebody who's sitting here and celebrating a great match, or somebody who's disappointed about where they matched, or somebody who's worried that they didn't match. I think anyone who is dedicated to medicine to show up here um, has probably enough passion to break through any medical wall. So it feels really cool to share the space with you. The other big picture first is this is the first VMR after a little bit of a frame shift that I would love to speak with you all about for just 1 minute. And that frame shift, I think, was very well summarized um, by my friend and colleague Omaima, who is in our CP Solver's reflection about this change was commenting on the fact that we often say the base rate would suggest condition X, but that is unlikely because this is CP Solvers where the base rate is very much esoteria. And we really enjoyed discussing esoteric cases and in reflecting on our diagnoses in general. Most of the time, probably about 80 to 90%, we have a relatively uncommon diagnosis. And 10% of the time or 20% of the time, we have a really interesting presentation of a common disease. And I just wanted to vocalize explicitly that our goal within VMR is to try to change that ratio a little bit. Not too drastically, because we all love our rare conditions and love learning from them, but we're hoping to make it like 70-30 or 60-40. Still a majority of really cool conditions, but really want to empower all of us to realize the value in thinking through common conditions and thinking about the rich amount of learning that happens in them in the least bit to be able to better care for our patients who commonly come with common conditions, but also to showcase the reality that a journey towards a rare disease involves meticulously excluding the more common conditions. And doing so with precision and clarity requires us to tackle those common conditions head on. So we're going to be doing that much more deliberately going forward. And for everyone listening, including on YouTube, this is a call for you all to really bring in cases that have very common diagnoses, because we want to highlight these cases and want to learn from them. I will emphasize that the case review committee is still open and will always be open. This really is a method by which anybody can submit their case to be mentored and coached both in how to put the case together and how to present it by a CP Solvers team member. And all you have to do is what I'll show you. You just have to go to our website, which is clinicalproblemsolving.com. And then you hit on morning report. And here, if you haven't signed up on YouTube and you're just watching these, highly recommend you sign up to join us live. It is way more fun. And then also you can click here to present a case. What will happen is we will connect you with one of our beloved team members who will literally walk you through the whole process and even show you how to add it to your CV. So think of this as a poster presentation or any impact use of your case. And I guarantee you that many more people will benefit from it when you put it in this space. So that's a first. That was a long one. I said a minute, but of course I lied. I'm also really excited to be joined by the first time by my friend Navpreet, who has been part of the CP Solvers family for approaching a year. And I think what you see now in Navpreet is really symbolizes his involvement in CP Solvers. He always has the deepest smile on his face and the most curious approach to medicine. He made a tremendous impact initially as a VMR community member with basically the most prominent repeat presence on VMR. He was here like every day for months and months and months and months and months, and continued to bless us with tremendous impact when he became part of the CP Solvers Academy. He is celebrating matching last Friday, but balancing that with working very, very hard recently. So we've missed him in VMR and excited to share the stage with him. I'll pass the mic to him to say hi, and then I'll steal it back from him to introduce our case presenter.
Thank you, Ravi. Thank you for so many such kind words. And TP is always such an amazing family. I love to be here back in time and again. And yeah, I can say proudly that I am an incoming PGY1 internal medicine resident at Mercy Hospital in Arkansas. And
Woo!
looking forward for the case discussion today. Thank
Amazing.
you.
We will have so much fun. I'm really proud of you. Kudos to many, many, many years of hard work to get where you are. Um, and another final first, there are four of them. Can't believe I remembered all of them. But this one is the most meaningful. We have our first time case presenter, Laura, who's joining us on VMR. Laura, do you mind telling us a little bit about yourself?
Sure. Hi, everyone. My name is Laura. I'm a PGY1 internal medicine resident at Emory. One of my wonderful senior residents, Yusuf, had told me about you all and asked if I'd be interested in sharing a case. And I'm very interested in um, care for people living with HIV. I feel like I'm hoping for that to be part of my career in the future. And that's kind of my career path. And I'm excited to be here with you all today.
Amazing. Laura, it's amazing how many, I think Yusuf is the case presenter coach extraordinaire. I'm really glad that he has convinced you to be here, and we're thrilled to have you. We're going to talk a lot about medicine and talk about probably your medical interests, but I'm really curious if you wouldn't mind telling us who you are outside of medicine. What do you like to do? Who is the Laura without the MD?
Sure. Let's see. I grew up in Virginia, lived in New Jersey for a while. My
Yeah.
family's all there. Was in Chicago for the past 8 years and love being in Chicago. I love spending time outside and hiking and running outside whenever I can. And still new to Atlanta and having a good time exploring here. There's a lot of
Yeah.
good food here.
Yeah.
So those are some of my favorite things to do.
Amazing. That's so wonderful. And so you've been in Atlanta for just over 9 months now. What's your favorite part, would you say?
Let's see. I think that the best thing so far is how many places there are to be outside. Just and there's a bunch of state parks really close by, and so almost every weekend tried to go on. It's real easy hikes, more like nice nature walks with some friends and with my partner, and all of these different state parks around the area so far in Atlanta. It's been wonderful.
Amazing. Yeah, I've heard so many great things about the green spaces in Atlanta. One would assume it's like a major big city, and I feel like when I picture that, I see more glass than green, but it sounds like Atlanta, that might not be true. I've never been, but not the least to see Yusuf and many other beloved people in Atlanta. I gotta make a trip out there.
Would
How did
highly
you,
recommend.
yeah, it sounds like it. How did your interest guide you towards wanting to take care of patients living with HIV?
Yeah, this interest started back in college for me. I was really interested I studied like international development and poverty alleviation. And as I read more in that space and about um, the conditions that generally affect people who are poor and experiencing marginalization, I learned more about the history of like the HIV epidemic and how people historically living with HIV and currently to this day in a lot of areas really experience so many layers of um,
Mhm.
stigma, discrimination in a lot of cases, and many layers of marginalization. And I've really found that that space and where so many like intersecting identities come together is really interesting and a space that I feel like there's so much potential for growth and being able to provide really comprehensive medical care for people in that space I know is so important, but I also feel like that kind of comprehensive approach is really important for health of an entire community and taking care of a whole person and seeing all of those aspects as being interconnected is really how I view the world in general. And so this area of medicine just kind of
Yeah,
fits really well with my whole
yeah.
worldview. And so it's kind of
Yeah.
where this all came from.
Oh my gosh, that's so well said. And I think really resonates with me. I think all too often the care of a patient is siloed into different aspects, like diagnosing them and treating them, and then the social dimensions of their care. But they're really, I think, to be a good doctor, you really need to address all of them and keep the humanity of your patient front and center. And interestingly enough, that's been the theme of our last two cases that I've discussed. On last Thursday, we had a tragic case of a young patient who was 8 or 9 when he developed a devastating condition. And that I don't want to ruin the diagnostic aspect of the case, but because he was so young, it was so clear that he hadn't developed the coping skills to manage having 17 different medical problems, and that it profoundly influenced his ability to engage in care and his desire to stay in the hospital. And I think recognizing that, that's probably the most important problem, or more most important issue to address. And then on Friday, we had a really tragic case, the Friday before, a tragic case of somebody who had essentially died at the age of 30 as a result of alcohol use disorder. And the stigma associated with that and the consequences associated with that are enormous. So I've babbled a lot. I'm really, really excited to hear your case, and I hope that we can address all dimensions of the care for the patient. So take it away. We're ready whenever you are.
All right, wonderful. So starting off with the chief concern is altered mental status. And so going into the history here, this patient was an unidentified, unknown aged male, likely 30s to 40 years old. This patient was found obtunded on the ground at the bus station in Atlanta. He was soaking wet and was minimally responsive at the time. Per the EMS report, the patient's systolic blood pressure was in the 80s on arrival to the ED. He was empirically given naloxone once in the ED with mild improvement in his respiratory rate and his initial bradycardia. And so he was empirically started on a naloxone drip for presumed intoxication with a bit of improvement with that initial dose. And then for the rest of the ED course, the patient also received empiric antibiotics with ceftriaxone, vancomycin, also received high-dose thiamine and fluids as well, and then was rewarmed with a bear hugger and was admitted directly to the ICU.
Laura, wow, this is very, very interesting, and not an uncommon scenario where a patient has so many active problems going on. Now, Preet, it's impossible to know where to begin in this case. And I think one helpful exercise is just to bullet point and list all the problems your mind has registered. So, what would you say if you had to like literally bullet point each problem? What would you call the problems that have landed on your brain so far?
So, thank you, Laura, for the chief complaint. So, the first thing when Laura said the altered mental status, right? So, and the thing is, when it was unidentified patient, and then he was found in a bus stop, right?
Right,
So, and the first thing that came into my mind was I don't want to buy myself, but like some drug overdose, and they have done the rightly thing in the ER as well, giving the patient naloxone.
right,
But whenever we have a patient of altered mental status, I would definitely want to know about when he was last normally behaving, active, and then what is the time duration of the symptoms. And other than that, for altered mental status that is coming in my mind is
yeah,
what are the pre and post symptoms of the patient? Is there any confusion, or is there any like seizing activity that somebody noticed? And for altered mental status, as we have discussed in the previous VMRs, the mixed mnemonics is coming in my mind to look for the various different differentials for like being it like unidentified male, could be metabolic, could be hyper or hyponatremia. Hypoglycemia is that one another thing which is coming top in my mind. It could be hypoglycemia that make the patient go into unconscious altered mental status
mhm,
condition. Other than that, I stand for infection if there is any underlying infection. And as Laura told us in the ED, they have given the patient empiric ceftriaxone vancomycin to cover broad spectrumly to cover if there's any shock developing.
mhm,
And then S stand for any structural thing. That's gonna be another thing that would be in my mind. since patient is having some bradycardia, it could be one thing definitely can be some opioid overdose,
Mhm.
or there's gonna be something that has been going in the brain or in the heart that is causing the patient bradycardia.
Yeah,
And then T, as we discussed, the toxins. Like
you are.
these are the all things that are coming in my mind from this first
Right.
eloquence.
Yeah, so let's do that. That was excellent. Absolutely superb. Very well organized. So let's do actually a simpler exercise. So I'm gonna summarize what you said. You said your problem list includes altered mental status, bradycardia, hypopnea or a low respiratory rate. So without analyzing the problems, is there anything else you want to add to the problem list? Altered mental status, low respiratory rate, low heart rate, and anything else that struck your mind that you want to add, not to analyze, but just to the list of problems?
Would that be blood pressure?
I think so. I think yeah, hypotension. And then one
And
thing,
then
yeah, anything else?
carbon carbon dioxide level, like if we can get a stat ABG on the
Yeah,
patient to know if the
right.
patient is retaining carbon dioxide, that
Right.
is
We
another
don't
thing.
know that yet, right? That could be a problem, but in terms of trying to make a list of the problems now, have you heard, Navpreet, of a bear hugger? Have you heard of what that is?
Uh,
It
I
may not.
heard this terminology, but it's not
Yeah,
coming in.
it's very much US specific terminology. So I wouldn't be surprised if you haven't heard of it before. It is a bear hugger is essentially a device that is wrapped around the patient that helps warm them when they are hypothermic. So our problem list so far is altered mental status, low respiratory rate, low blood pressure, low heart rate, and low temperature. So I'm curious, of those things, altered mental status, low respiratory rate, low blood pressure, low heart rate, low temperature, what do you think, which entity do you think has the smallest differential diagnosis? What's your
Mm,
instinct on that? Because the first thing we should decide is which is the problem that we should analyze first. So what do you think is the narrowest differential diagnosis?
is it the temperature?
Yeah, exactly. So let's take a pause here. Can you connect low temperature to low heart rate?
Some severe hypothermia can cause?
Yeah, exactly. Severe hypothermia is a common explanation for bradycardia. So now, just with that knowledge, you can actually say, I don't care about the bradycardia unless the EKG shows me something unusual. The hypothermia explains the bradycardia. The question is, does the hypothermia explain the low respiratory rate? What do you think?
No, I don't think so.
Yeah,
Like it
yeah,
can be related, but again, like there are other reasons to have a low bradycardia.
right. Yeah, I completely agree with you. I think that the connection between a low heart rate and a low temperature is much stronger than the connection between a low temperature and a low respiratory rate. However, it is actually fairly well described in patients with hypothermia to have hypopnea. Basically, everything slows down, including the respiratory rate and the heart rate. And so I think if we're being honest, we're saying, is my problem truly altered mental status, low respiratory rate, low heart rate, low blood pressure, and low temperature? Or is my problem truly just severe hypothermia with its clinical consequences? And I think that the temperature value itself will be able to tell you the likely answer. If the temperature is just slightly hypothermic, then no way. There must be something else going on. But part of trying to take care of these patients is to understand what the core problem might be. And just like you, I'm still thinking altered mental status missed. I'm still thinking low respiratory rate, opiates versus brainstem. I'm still thinking bradycardia, sinus versus AV node. I'm still thinking hypotension, distributive. I'm thinking all those things. But in order to be able to move the case forward, I need to also simplify it in my mind. And so I think for now, the operating framework of hypothermia being a core feature of this case is helping us make progress. So let's pause and reflect on that. How do you approach the causes of hypothermia? What has been your experience or your reading on hypothermia?
So, for any patient of hypothermia, there are three types of hypothermia: mild, moderate, and severe.
Excellent.
And for the mild thing, we just do passive warming and we give the patient blanket to see if it is helping the patient or not. If it is between 92 degrees Fahrenheit to 94, we give them warm blankets and heated blankets, and less than 92 degree, we kind of give them warm fluids. Um, that's what is coming in my mind.
Excellent. Yeah, that's exactly right. That's exactly right. And the fact that he was put on a bear hugger tells you that this is not just mild hypothermia. So I will encourage all of you as we think about the management to think about the underlying causes of hypothermia. But first, let's pass the mic to Laura to get more information, and then we can revisit this space. All right, Laura, tell us more, please.
All right. All right, so going into for past medical history, medications, and social history, we don't actually have any of that information since this patient was an unidentified and unknown patient. And so no further details there. In terms of the patient's vitals in the ED, first I have the temperature was 30.4 degrees Celsius. Heart rate was 55. Blood pressure was 121/87. And he was satting 100% on room air, and respiratory rate was 15. For the physical exam, for general appearance, he was in no acute distress, laying in bed, and GCS was 7. Score was 1 for eyes, 1 for verbal, and 5 for motor. For the neuro exam, the patient was obtunded, not responding to commands, only grimacing to pain, and not localizing to any specific area. For HEENT exam, only notable for superficial abrasions over the left eyelid and had pinpoint pupils bilaterally. For cardiovascular exam, the patient was bradycardic, but the rhythm seemed regular. There was no murmurs, no peripheral edema was appreciated, and the peripheral pulses were all intact. Pulmonary exam was not remarkable. The lungs were clear bilaterally, no crackles or wheezes. Abdomen exam was also not remarkable, soft, non-tender, non-distended, no organomegaly. And for GU, a Foley was placed in the ED and clear yellow urine was draining.
Oh, Laura, I absolutely love that you're presenting this case. I think, as we talked about earlier with trying to bring common presentations to VMR, this circumstance is a very, very common and tragically, a very, very common one where we have no information about the patient and we know that they're in extremis. I'm curious now, Navpreet, what do you think? I'll just ask you for one thing in this case, then we can talk in general. How are you thinking about the degree of hypothermia in this case, and have you considered any possible causes for the patient?
That's a really good question, Rabi. I don't know about the location where the patient was found, what kind of area it was. So if Laura can you like give us that information, if like it's snow there or what kind of temperature was there in the area?
And what you're thinking here is actually one of the most common causes of hypothermia, which is exposure-related hypothermia, where a patient loses body temperature as a result of being out in the environment. Excellent. What other thoughts do you have to share about hypothermia? Anything treatment-wise for this patient, causes, what else is crossing your mind?
So I definitely want to see if there is any cyanosis on the body, if there is any shivering present,
Yes.
and from this physical examination, if I'll pay attention, the other thing which is catching my attention is heart rate that we have discussed,
Good.
and GCS score of 7
Yeah.
with pinpoint pupils and some abrasions. So I don't if like the thing that coming in my mind would be some sort of like I'm keeping that as one of the differential if there could be any trauma to the head or
Excellent.
some drug overdose that can also cause a low GCS score and like some injury or some something that has happened in the like some trauma or something happened when the patient patient have as a result of which patient kind of lost her consciousness his or her consciousness outside, and that can lead to a low temperature hypothermia. That is one thing that is catching my attention, and then bradycardia is there, and and we definitely need to dig more with the past medical history and the medication what patients are taking. So medication, if patient is taking any insulin, like patient is diabetic, so or if there's any endocrine issues like hypothyroidism can also cause bradycardia, hypothermia. So these are the things that are coming into my mind by this physical examination.
Absolutely excellent, outstanding. And I will explain to you why your thinking is in this patient is very broad and appropriate, but I'll take a moment to break it down a little bit more slowly. So let's just talk, because we don't get to talk so much, about the differential diagnosis of hypothermia. We're going to have this conversation in general without using the case specifics. And in general, there are three common causes of hypothermia. One is loss of temperature, loss of heat through environmental exposure. The second is loss of heat due to vasodilation from sepsis. These two account for the vast majority of cases of hypothermia. The third is not as common, but is important to think about, which is medication-induced impairment of shivering. There are several medications that can do this, including the antipsychotic medications. So those three are the things we have to run through. And you can already see that Laura and her ED colleagues are treating the patient for one of them, sepsis with antibiotics, are treating the exposure by putting the patient in a warm blanket. And then unfortunately, we don't know what his medication list is. If you're trying to have a comprehensive approach to hypothermia, you'll just ask, is the patient having excessive heat loss, either through the environment or through vasodilation? Or does the patient have impaired heat generation? And impaired heat generation is either because the patient has no body fat, anorexia, has no muscle activity, impairment of shivering, or has impaired signaling, either impaired neurologic signaling through hypothalamic diseases or impaired endocrinologic signaling through hypothyroidism. So increased loss, exposure, vasodilation, impaired generation from no body fat, no muscle activity, or no signals from hypothalamus or endocrine. But here's the problem. Hypothermia can cause altered mental status, or altered mental status in the wrong place, specifically altered mental status in place of an environmental exposure, can cause the patient to collapse and then cause hypothermia. The single most important step here is to be open to AMS causing hypothermia or hypothermia causing AMS. But this patient, we have to treat him for the three most common causes: sepsis, number one, environmental exposure, and I think analysis of the causes of altered mental status has to include non-hypothermic causes, because it easily could have suffered a trauma, like you said, and then found himself exposed and became hypothermic. My final question to you before we move on is what your differential diagnosis is of pinpoint pupils. How do you think about that condition since it's present here?
Um, so with this patient having respiratory rate of 15 and blood pressure is also maintaining, uh, I am suspecting some hemorrhage or stroke in a head. Some increased intracranial pressure can cause pinpoint pupil. Opioid overdose is not very high on my list after seeing the respiratory rate and blood pressure, to be honest. And uh, that's kind of, I would love to hear your thoughts onto it.
No, you nailed it. You nailed it. I'll just say that whenever the pupils are either small or big, you'll never know if it's a lot. So if they're small, it could be excessive parasympathetic tone, or it could be loss of sympathetic tone. So as an example, cholinergic toxicity will cause pinpoint pupils, but also Horner syndrome, which is loss of sympathetic tone, will also cause pinpoint pupils. But you can actually cheat. Loss of tone results in unilateral pupillary abnormalities. So for example, if you have Horner's, you'll only have one side that's small and the other will be normal. Or if you have cranial nerve 3 lesions, only one side of your pupil will be big, the other will be normal. The bilaterality of pupillary changes is always as a result of excess. So bilateral pinpoint pupils is as a result of parasympathetic excess. And that is either the result of intrinsic brainstem disease or the result of the 2 T's: toxins, opiates and cholinergic medications, and temperature, hypothermia. So here, hypothermia is a very reasonable cause for his pinpoint pupils, but we have to make sure there isn't a toxin like cholinergic or opiates, and there isn't an intrinsic brainstem problem such as an intracranial catastrophe. It's really important to recognize that a lack of response to naloxone does not mean the patient does not have an opiate overdose. It could mean the patient does not have an opiate overdose, or it could mean that one has not given enough naloxone, say in a long-acting opiate medication. So in this case, the decision facing the treatment team is, do you put this patient on a naloxone or Narcan drip in case there is a long-acting opiate such as methadone involved in this toxidrome? All right, Laura, tell us more. We're very, very intrigued.
All right, wonderful. So next I have some of the basic workup labs from the ED. So I have the CBC. So first, this patient's white blood cell count was 2.7, hemoglobin was 12.6, hematocrit was 37.8, platelets are 227. On manual diff was ordered as well. Neutrophils were 2.5, lymphocytes were 0.1, monocytes were 0.1. And then I have the CMP. So sodium was 131, potassium 3.4, chloride 93, CO2 24, BUN 22, creatinine was 0.7, glucose was 133, calcium 8.5, protein 6.5, albumin 3.1, ALT 19, AST 28, T-Billy 0.7, D-Billy 0.1, and alk phos was 67. A few other initial things that were gotten in the ED as well was a troponin, which was 2. Lactate was 2.4, and then repeated was 1.3. And then a UA was obtained as well. That was just notable for 2+ protein, 2+ urobilly, and 2 to 5 white blood cells per high power field and less than 3 red blood cells per high power field.
See, thanks so much, Laura, and thank you, Yaz. Appreciate you. Thank you for sharing the screen. I mean, I'm so sorry. I'm guessing you're probably having internet issues. Really, really sorry. And thank you for your heroic efforts despite the technology not necessarily helping out. And maybe while the scribe team catches up, Laura, I'll just sort of summarize for everybody's benefit what I got, which is that the patient had leukopenia with relatively preserved hemoglobin and platelets. I don't think I registered anything markedly abnormal on the liver panel or the electrolyte panel, but did note, which is actually noted on the whiteboard, proteinuria and pyuria. And I forget how many red blood cells there were.
Less than 3.
Less than 3. Okay. Any adjustments to that summary of the labs?
Nope, that's right.
Awesome. Okay. All right. Terrific. Thank you so much. So Napreet, what are you thinking with this data?
I'm actually very intrigued with the labs. I was expecting it to be like a little abnormal, but the labs seem pretty normal in the first glance. CBC, CMP is normal. Sodium, potassium, they are borderline normal. So depending on the labs, I think that this is something acute event going on that has caused altered mental status and not any underlying chronic event because of the labs.
Yes.
And I don't know, Laura, can you like tell me what are the drops and do we have a lactate level on this patient?
Could you repeat that? I
I
didn't hear you.
Naprit
the
was,
lactates.
if the trope was, I think, 0.2, if I remember correctly.
The trope was 2 and the lactate was 2.4.
2.4. So both, yeah, not super high. Yeah.
Yeah, I would definitely love to hear your thoughts on the urine analysis being 2+ proteins. Like, what are the like different reasons, like clumping everything together, patient having hypothermia, or like bradycardia, and pinpoint pupils with urine analysis. I am kind of little confused. What are your
Yeah.
thoughts on this, Rob?
Oh, for sure. I think you have to be very careful about not over analyzing the data because, as you said, the labs, for somebody who's this sick, you expected acute tubular necrosis, significant liver injury, high lactate. And I agree with you. He must not have been this sick for that long. Otherwise, he would be in much more deep trouble. So I think that's the only really powerful conclusion from this lab. So don't undersell yourself, my friend. You don't need my thoughts. This was excellent. But now the goal in Naprit is to practice. So I'm going to ask you for a favor. Take yourself outside of this case and say the only thing you know about a patient is that they have isolated low white blood cell count. What kinds of things cross your mind in general about isolated leukopenia?
The first thing that coming into my mind is HIV,
Excellent.
some immunodeficiency syndrome that is causing leukopenia, because that's the only positive finding that we are getting in this patient. With low WBC count, it could be some sort of sepsis going on. As a, like, because of the immune deficiency, we are not getting the WBC count. That can be one of the reasons giving us a false negative results on the WBCs. And other than that, some tumor or some malignancy that can cause low WBC counts. These are my thoughts. What about you, Rob?
Excellent. Superb. There are many causes of isolated leukopenia, but it's helpful to know one in each of the 4 categories: infection, HIV, and sepsis. That's why leukopenia is part of the search criteria. Infection, HIV, sepsis. Autoimmune disease, lupus, 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 lupus. Drugs, anti-thyroid drugs. Really, really important to think about it. And then cancer is not so common to cause isolated leukopenia, but since this is VMR, LGL, large granular cell leukemia, notoriously causes a isolated leukopenia. So here in this patient, sepsis possible, but the patient doesn't seem to have the laboratory features that often accompany sepsis: liver injury, kidney injury, as you said. So could this be HIV? Now, again, another favor. Go completely outside of this case. When you see proteinuria, at least significant proteinuria, 2+, what kinds of, what label do you apply to that? Nephrotic, nephritic? What kinds of words come to mind when you think of a lot of proteinuria?
With no RBCs and no hypertension in this patient, nephrotic syndrome is
Excellent.
what coming in my mind.
Excellent. Why do you need my
And
thoughts? What
then
what causes nephrotic syndrome?
so with low WBC count, it could be HIV-associated nephropathy, HIV-associated nephrotic syndrome, or some autoimmune disorders can cause nephrotic syndrome. And
I agree with you.
some, I guess if I'm not wrong, drug overdose can also cause nephrotic syndrome or
Not
not.
so much. Not so much. There's
I'm
some
not
drugs,
sure.
sure. Definitely some drugs can do it, but not so much. So look at you. You looked at this labs, you're like, he's not as sick as I thought. Excellent. You looked at that white count and you said HIV, HIV. You looked at that protein and you said HIV and maybe autoimmune disease. And the one autoimmune disease that causes leukopenia and proteinuria is lupus. But discovering HIV is way more important right now than discovering lupus immediately, though both are really important. So let me just summarize. we have a really, really unfortunate case of a very vulnerable human being who was found soaked on a bus stop. And no matter what, we know that this patient's problems are going to be very, very complicated, but we need to really focus on saving his life right now. And we'll do that in two ways: rewarming him, not making any assumptions about the cause of his bradycardia or the cause of his hypopnea. We have to make sure that we think about IV or more Narcan, pending a urinary drug screen, which we will have soon because he's urinating a lot. We have to make sure his brain is okay with a CT scan. But as you said, there appears to be a signature of chronicity to what is otherwise appearing to be an acute problem. And I'm really, really proud of you that you did not miss the fact that while this patient appears to be acutely ill, the story seems to go well before him being found down at the bus stop. Excellent recognition of that. And so let's find out more from Laura.
All right. So next pieces of information for this patient's EKG in the ED, they had sinus bradycardia, 49 beats per minute. T-wave inversions were seen in leads 3 and AVF. The QTC was 543, and it met criteria for LVH. As far as imaging goes, everything went straight to a pan scan of CT head, chest, abdomen, and pelvis rather than getting an initial chest x-ray. So for CT head, the read was notable for some hypodensities in the cerebellum. The radiologist commented that these likely represented chronic infarcts, but there's no comparison. For the CT chest, was notable for a few peripheral ground glass opacities on the right lung, concerning for possible contusion to the right, to like the right side, right and right flank. Also noted a few pulmonary nodules. The right lower lobe had a nodule measuring 1.8 by 1.4 centimeters, and left lower lobe had a nodule measuring 7 millimeters across. And there were no acute findings in the abdomen. I have a few other ED labs that I could share as well. All right, so other things obtained in the ED, blood cultures were collected. INR was 1.2, CPK was 201, a TSH was 1.63, and some other labs included acetaminophen levels less than 10, ETOH was less than 10, salicylates were less than 10, and a urine drug screen was negative.
Thank you so much, Laura. I think you're presenting this in such a, as a pro, this is really, really stretching our thinking here. Thank you. So Napreet, I have one very hard question for you. You got maybe about 10 pieces of information. Honestly speaking, which one did you find helped you the most make progress of all this information? Which data really said, oh, wow.
To be honest, all this information is really interesting to me. Like starting from EKG being a QT elevation, then some hypodensity in cerebellum and CT chest as well.
Yeah.
So CT chest, I would say, is more like giving me more clues to the diagnosis. But patient there's a lot going on. So it could be some heart issue that can cause like some cardiac problem that is throwing up thrombosis, emboli into the brain that can cause some hypodensities in cerebellum. Then CT chest with some contusion on the right side and few pulmonary nodules. Patient found on the street having WBC low count is pointing me towards some immunodeficiencies that is causing some infection in the lung. Some nodules can be because of some infection or some kind of some inflammatory disease that is developing in the chest that can cause these nodules. So I would definitely want to know what these nodules are made up of, and with the CPK is also elevated in this patient. Uh, CPK, I'm not
Good.
sure. So yeah, but I definitely would love to know your thoughts onto it.
Oh, I'm right there with you. I think that what has happened really fundamentally, if we center ourselves around the very sad finding of pinpoint pupils, we had three causes: brainstem, toxin, or temperature. The urine drug screen is not perfect, but certainly reduces the probability of opiates now being contributory, though it's not, and actually in my institution, it's very comprehensive. You get every single opiate we know, but some places you don't. So brainstem, temperature, toxin. Toxin is less. So if the patient doesn't wake up in the next hour or 2 hours with rewarming, then we have a brainstem problem. And the nature of the brainstem problem has to be taken in the context of the possibility of HIV and the fact that there seems to be a pulmonary focus of infection. So what did this aliquot do to me? The distance between 0 and lumbar puncture has gotten this small. You probably should do the lumbar puncture very soon, especially if the patient doesn't wake up with rewarming. Laura, what did you all do?
This patient did have a lumbar puncture very soon.
Good.
All right. So, initial LP studies for the white blood cell count for LP was 132 with 54% neutrophils, 36% lymphocytes. Glucose was 25. Protein was 226. At this point, I have a couple other studies that were obtained around the same time. Wonder if I should pause if you wanted to discuss the CSF studies first. Tell me what you would like to do.
Oh, I love your case presentation instinct. This is awesome. Yeah, I think it'd be really nice to just reflect on this for a moment. Maybe if you had it though, one other data might be helpful, which is did the team manage to collect an opening pressure at this time, or was that not available?
I don't have that data in front of me. I'm not sure.
No problem. No problem at all. And we can talk about how that can be helpful, but I actually will say in this instance is maybe not as helpful as it would be otherwise. So Napreet, what do you think about this lumbar puncture?
With the lumbar puncture having increased WBC counts with 54% neutrophils and low glucose, definitely I'm thinking of some bacterial infection etiology there that can cause symptoms like this. Uh, with bacterial, patient have low WBC count, can be I'm kind of blanking out, but some sort of meningitis can be there. Some with the confusion state, some encephalitis that can be there. What do you think?
Agree with you. Now, I'll ask you this question before we analyze. What do you think? Altered mental status caused hypothermia or hypothermia caused altered mental status? What do you think?
Altered mental status called hypothermia, I believe, in this
See,
patient.
that's the most important thing that you did. And I just want to commend you because you said that very early. You said, we don't know if this patient is confused because he has low temperature or he had developed low temperature because he has some brain problem. Initially, we were worried about seizure or stroke, but now we have the diagnosis of meningitis. So now we have a pathway to solve this case. And now we know what we need to do. What is the cause of this meningitis? So now, Preet, the first thing you should think about in meningitis is ask, could this be bacterial meningitis, just as you did? The most common causes of bacterial meningitis are strep, pneumo, and Neisseria. The reason we should think about them is they're deadly. The reason they're a little bit less likely in this case is the height of the white blood cell count. In most patients with white blood cell count with bacterial meningitis, the white blood cell count total is over 500. Here, it's only 132. The exception to that is early in the course, it may not be as high. So we still have to treat for those causes, but we're going to think about other causes of a meningitis. And that's where we use the diff, neutrophils versus leukocytes. Neutrophilia is consistent with early viral meningitis. Here, the degree of it, along with the low glucose, argues against viral meningitis. A low glucose is usually a feature of mycobacterial or fungal meningitis. So, Navpreet, when you think of mycobacterial meningitis or fungal meningitis, what kinds of organisms cross your mind?
Like like I didn't get the question. Can you repeat it?
Yeah, when you think of mycobacterial or fungal meningitis, what kinds of organisms do you think of in that category?
So for the mycobacterium, it could be tuberculosis, and for the fungal cryptococcus,
Excellent,
that can cause most commonly meningitis.
excellent. Excellent. I think that the nodules in the chest are very, very important here and may suggest TB. They may also suggest crypto. What is relatively unusual about Cryptococcus in this case is the height of the white blood cell count. The average amount of white blood cells in cases of cryptococcal meningitis is usually around 20 to 40. However, it can get this high. The serum and CSF cryptococcal antigens are the single most important test that you can get in the next few hours in this patient. This patient could also have TB and could also have endemic mycoses. The most prevalent endemic mycoses in Atlanta, I'll let Laura speak more about, but I've heard of cases of histoplasmosis in that area. But I think the most important next step for this person is empiric bacterial meningitis treatment, maybe even viral. But the test I'm really hoping for are AFB tests, cryptococcal antigen, and tests for endemic mycoses. In this patient with HIV, I think it's really interesting to see how disproportionate his brain is. As you said, his kidneys are fine, his liver is fine. The disproportionate skew towards the brain really makes us worried about Cryptococcus more so than other organisms, but TB and the endemic mycoses are very much possible. Did you have any other thoughts before we hear from Laura what happened next?
Definitely coming from India, TB definitely comes in my mind. But since in America it's not that endemic, I always kind of keep myself away. I'm like not think about TB. But this patient can have TB or some fungal infection going on, developing in the chest that is going to the brain and causing all the symptoms. But let's hear from Laura.
Yeah.
Honestly, the further information that I have will at this point um be diagnostic.
Yeah,
And
let's do it.
so I think I would can I ask you at this point for both of you, what would you lean toward as your highest on your differential?
Thank you, Laura, for this exercise. I love it. What do you think? What are you leaning towards, Navpreet?
Well, I'm definitely leaning towards some bacterial infection in the chest, causing meningitis or encephalitis in the brain. Uh, Top priority can be tuberculosis, and then some, since WBC count is not that high with lymphocytes, I can also think of some fungal infection as you discussed with histoplasmosis, cryptococcus on my differential. Along with that, I'm little confused about the hypodensities that we are seeing in the cerebellum, and I would definitely want to know your thought on that.
Yeah, yeah.
What can be these hypodensities that are developing? Is it something related to brain, to the chest, or those hypodensities? Like I would, if of course this patient has been found unidentified on the street, but if it could have been some other patient, I would definitely review their past CT head or CT chest or CT or X-ray if we have in the past to compare what is the time course of these hypodensities and what they look like. So these are my thoughts, but I would definitely want to know about your thoughts on hypodensities in the cerebellum.
Laurie noticed that he's not going to commit, and I think that's probably it's impossible to actually commit to an answer. I love what the word you used, lean, and I think what we should do, Navpreet, is we should try to say how would we solve this case in real time. And I think there are two tests that come back very quickly in patients like this, which is what is the HIV antibody and what is the cryptococcal antigen. So if tasked with solving this in real life, I would say those two tests are going to profoundly influence. Because Navpreet, if we learn this patient is not immunocompromised, has normal HIV,
Right,
then we'll have to change our differential diagnosis like that,
right,
right? So those two tests are
right.
key. But if we try to get the most juice out of this case, I'll give it my best shot. So the cerebral hypodensities are infarctions, and you can get bilateral infarctions in the brain from two places. Anmol taught us that endocarditis can cause emboli to the brain, but I will also teach you that meningitis, by inflaming the vessels that exit from the subarachnoid space, can cause a secondary vasculitis. My suspicion is these cerebellar infarcts, since they are bilateral, represent arachnoiditis and inflammation extending to the cerebral vessels. Why is this helpful? It suggests the time course. Cerebral vasculitis from infectious meningitis is often in the subacute category. Meningovascular syphilis is the most famous example, but TB, crypto, and cocci are well described in doing this. So I don't think this person has syphilis because of the low glucose. Usually in syphilis, the glucose is not low. So is it TB? Is it TB, cocci, or crypto? I think that the argument for crypto is the disproportionate devastation in the brain and the relative sparing of the systemic organs, reflecting its profound tropism for the brain. The argument for TB is that the patient's white count is higher than it would be for crypto. What would I lean towards? I suspect this person has had this syndrome for quite some time. Why would I suspect that? I worry that he was so reluctant to seek care that he didn't even choose to seek care until he was forced to by his body's ability to not cope with it, suggesting that he's been suffering from this for a long time. So that's why I would break the rule for crypto, and I can see how it accumulated a lot of devastation, disproportionately so. So my leaning is towards HIV and cryptococcus, but it's a lean. I would hate to make that mistake and lock in real life and be wrong. All right, we're at well, we can talk for however, really. But Laura, I want to be respectful of your time. What did you find and what happened next for the patient?
Absolutely. So beautiful discussion, thinking through all of that information. And so the first piece of information that came back for this patient from what was initially drawn in the ED was this person's HIV test. And so they were found to be HIV positive with a viral load of PCR was 1.26K copies. And then their CD4 count came back at 21%. For further studies that were done from the LP, the cryptococcal antigen from the CSF was 1 to 1,280, and which confirmed our diagnosis of very severe cryptococcal meningitis in a person who was profoundly immune compromised due to HIV. So for other CSF studies, they non-reactive CSF VGRL, negative JC virus DNA, and then the had a MTB PCR that was negative as well, and AFB culture were negative from the CSF. Interestingly, just for this person's rest of their course, if I could just go through quickly how the rest of their course has gone.
Please don't rush. Take your time. This is really
Sure. It was a really very long and winding path for this gentleman. So um, his mental status unfortunately did not improve. He remained obtunded persistently. He had an MRI brain soon after we had these initial studies that showed diffuse leptomeningeal enhancement as well as significant hydrocephalus, multiple diffuse subacute infarcts, as you had kind of predicted, and possible ventriculitis. He soon after this had an aspiration event that he developed acute hypoxic respiratory failure requiring intubation. And at that point, he developed very severe diabetes insipidus and had very excessive urine production in the NICU. He was treated for that, required multiple different medications, but the next things that happened for him, he was started on induction therapy for the cryptococcal meningitis with amphotericin B and flucytosine. He briefly had a lumbar drain placed to manage the elevated ICP. It didn't function well, and so it had to be removed. And so he ended up having serial LPs every 48 to like 72 hours for the just to manage that ICP. And so like you were saying, even though the CSF PCR for MTB was negative, he ended up being empirically started on RIPE therapy just because of the such significant high mortality rates from any possible TB meningitis. He was covered just for that possibility. He also, throughout his very prolonged stay, was found to have treated for PJP pneumonia as well. And then on subsequent LPs was found to one was positive for HSV6 as well. And he later, of course, was complicated by infectious diarrhea as well in the while he was in the NICU. Eventually, this patient was identified, thankfully, about 3 or 4 weeks into his NICU stay. He had been fingerprinted by the police department, and we were able to identify him and contacted his mother. And so he, unfortunately, his neurostatus never really changed, and he remained obtunded, ended up undergoing a trach and peg, and he was eventually discharged he came in late December and was discharged in February to a long-term care facility.
Laura, I don't know what to say. I think this yeah, it's just heartbreaking and it's tragic that somebody got to this point, but it's also just an incredible case of your team and your colleagues' ability to recognize the severity of this syndrome and get an LP so quickly in this patient. I can't tell you the number of times that I've heard of or seen where the connection of hypothermia to altered mental status is made in the wrong direction. And I'm proud of Navpreet for realizing that very early on. And I'm very impressed by you guys of realizing it and doing it in real life. And then I think the way you shared this case really allowed us to have to work very hard towards the answer, not giving us the HIV until the end, but giving us the reality of the clues that were there early on, which is the leukopenia and proteinuria. Just a great storytelling that really maximized our educational hour. Thank you so much. I really hope that that you continue your growth towards taking care of patients with this condition, because I think you're already making an impact in that space. Thank you.
Absolutely. Well, thank you so much. And you honestly pulled out such important details out of these just like basic initial labs that I was very impressed. You honed in on the most important details for this patient. And so thank you for going through all of these topics so carefully. And I really appreciate the discussion for hypothermia of what order did these events happen in. And so wonderful.
That's the beauty of this community. We're trying to get to our serve our patients by getting to our maximizing our diagnostic skills, and which are really, really important. And I'm very grateful for Navpreet for being vulnerable today and sharing his thoughts and recognizing the key things not to catch the whole way. If you watch this video again, you'll see that your mind was latching onto every single detail. No slips were made, and the extra joy of actually thinking of the final diagnosis at the end, which was really cool. How do you feel now, Navpreet?
Thank you, Ravi. It's an honor discussing a case with you. And thank you, Laura, for bringing such an interesting case. And you guys take really good care of the patient. But it's a really interesting patient with having altered mental status found unidentified on the street, and with all these findings of hypothermia, bradycardia, and finally diagnosing of final diagnosis of cryptococcus meningitis and HIV. Really interesting case, and it was a full-blown roller coaster ride for me today. But I totally love every second of it. Thank
Yeah,
you, Laura. Thank you, Ravi.
absolutely amazing, Navpreet. I see Shreyas is doing the teaching points. And Shreyas, since we're a little over time, maybe I can ask you to hit the highlights, the key things that you took away, and then we'll call it a day.
Sure. Thank you so much for this case, and Uprit, you were amazing. So I'll just go over some of the interesting things which I learned. The approach to alternate mental status is always going to be our very favorite mnemonic at CP Solvers. So we can think about metabolic, infectious, structural, and toxins. And we had our diagnosis in the infectious category for this case. And then we also saw that our patient had hypothermia. He had a low heart rate, a low respiratory rate, and a low blood pressure. And so Dr. Rabih taught us that whenever we encounter so many problems at once, it's always useful to create a problem list. And so that's exactly what we did here. And so we felt that the great bang for our buck would be chasing the hypothermia, because it has the least extensive differential, and the most common cause is always going to be exposure related. And when we think about the differential diagnosis of hypothermia, we can think about it in three buckets. We can either think about it as loss of heat, or due to the environment, or vasodilation, and also medication induced, or anything which impairs our natural response to generate heat. So that those can be some important considerations. And as we moved on with the case, we also noticed that the patient had pinpoint pupils. So we also discussed the differential diagnosis of pinpoint pupils, which can again be three different things. Or we can rather put it into two different buckets. We can either think about it as excess of parasympathetic tone or loss of a sympathetic tone, and then we can think about various conditions. And a very interesting pearl which Dr. Rabi taught us was, when we think about bilateral pinpoint pupils or bilaterally constricted pupils, it's more likely going to be a parasympathetic excess rather than a loss of sympathetic tone. So that was a very interesting point. And we also had isolated leukopenia, and we again had three different things which we really need to think about. And in infection, we can think about HIV or sepsis, and low leukopenia also forms one of the ESSERS criteria, so that's important to keep in mind. Autoimmune, we can think about lupus, but that can also affect other cell lines. And when we think about some rare causes like drugs, for example, antithyroid medications like propylthiouracil, and also malignancies, we can think about large granulocytic lymphocytic leukemia. And as we progress, we realized that lumbar puncture was of paramount importance, and that's exactly what gave us the diagnosis. We saw low glucose and neutrophil predominance, so we began thinking about fungal as well as bacterial meningitis. And we also had infarct, so that was concerning for a meningovascular picture, which is because of extension of the meningitis. So whenever the arachnoiditis extends into the vasculature, like Dr. Rabi taught us today, so that can also cause infarcts over a long term. And ultimately, cryptococcal meningitis was the culprit here, and the treatment for it is amphotericin B with flucytosine, and followed by long-term course of fluconazole. Thank you so much for this opportunity.
Absolutely superb, Shreyas. That was absolutely amazing. Thank you all so much. Thank you, Himena, for powering through the scribing, and for Yaz, Deborah, and others who supported her. Thank you, Navpreet and Laura. That was so much fun, and hope to see you all on VMR tomorrow. Bye.
Thank you so much for having me.
It was a real pleasure. Thank you.
Hi, guys.